morning, students. In continuation with our last class where I dealt with carcinoma of the lip with the surgical excision, also followed by hemimandibulectomy if needed when the mandible is involved. Now, just to cover up, finish up the topic, I would like to talk to you about the various reconstruction procedures that we do to carcinoma lip. Here, you just need to know about the names of the flaps and what is being done. That's it, not more than that. You just have to remember the names. Even if you just mention the names, that would be enough. Just try to understand what is being done in order to reconstruct the defect. Okay? So, the methods of reconstruction here are through a rotational flap. This rotational flap is taken from one area and rotated to the recipient area, the defect area where there is a defect, along with its blood supply. Okay. So just need to remember the names: B Ushaswini rotational flap, thrice modified Bernal facial flap. There are certain microvascular flaps, also the nasolabial flap, free radial artery flap, W flap plastic, release fan flap. So what is done here in Eggie's flap? Here, Eggie's flap and Eggie Ushaswini's flap, we use these flaps when the involved area of the lip is less than half of its total surface. So, Eggie's flap is one that is taken from the lower lip or the upper lip. And it has to be, it is based on the, if it is lower lip, the inferior labial artery. It is rotated onto the needed area where there is the defect after removal of the tumor. So the excised bed, here this flap based on the, here the lower lip flap which is based on the inferior labial artery is rotated onto the excised area. The most common, here the defect should not be at the angles. It can be anywhere along the lip, not at the angles. So once when this flap is rotated onto the defect, here you have the base of the rotated flap that has to be excised later on as a second surgery. So this is Eggie's flap. Next is Eggie Ushaswini's flap. The only difference is it is just a modification of the Eggie's flap. And the only difference is here even the angles can also be involved. And the flap that is based on the labial artery is rotated onto the defect. Here you need not excise the base at the, here this is the tumor and the defect. The standard flap based on the upper lip, labial artery, superior labial artery. It is transposed onto the defect area on the lower side. The base need not be excised at a later stage. This is the advantage of Ushaswini's flap over Eggie's flap. Okay, the next flap is Bernal facial flap. Here it is used for the central lip tumors, wherein the angles of the lower part of the defect and the upper part of the angles of the mouth are rotated inwards, such that there is formation of these Burroughs triangles. Burroughs triangle is nothing but a triangular defect at the area of the donor site, full thickness involving the skin and subcutaneous tissue. It is made in such a way so that there is no buckling of the adjacent tissue. So when you close this area, it is a simple primary closure. There is no buckling of the adjacent tissue, and this is rotated inwards to cover over the tumor. Okay, this is Bernal's facial flap. Other one is Gillies fan flap. Here also the incision is full thickness around the commissures and extending onto the nasolabial fold and upper lip up to the mammalian border. Okay, this flap is based on the labial vessels again, and it is advanced towards the defect. It is advanced towards the defect on this side. This again requires reconstruction of the mammalian defect that we have created because of the incision. This is Gillies fan flap. Next is nasolabial flap. And there is extensive lower lip involvement involving the chin also. Wide excision of the tumor, the floor of the mouth is also involved. The flap is rotated onto the defect, onto the floor of the mouth. So there is a medial flap. As I already told you, prognosis in carcinoma lip is the best out of all the oral cavity malignancies, wherein the 5-year survival rate is as much as up to 70%. Nerve involvement fixation, the nodal spread, upper lip or lower lip, or the commissions, age less than 40 years. These all have poor prognosis. Coming to the topic for today's class would be tongue. Carcinoma of the tongue mainly. Firstly, let us talk about the anatomy of the tongue. Tongue is the muscular organ located in the floor of the mouth. Okay. So it has 3 parts, which is nothing but the tip, the anterior free end that lies behind the upper incisor. Tip. This is the tip that lies behind the upper incisor tip. The root that is attached to the mandible above and the hyoid bone below. Okay. And the body, this is the body. Dorsal surface is rough because of presence of papillae and is divided into anterior 2/3 and posterior 1/3. The ventral surface is smooth, that is the lower surface. Ventral surface has a median fold called the frenulum linguale and the deep inguinal on either side of this frenulum. So this is the ventral surface. The dorsal surface, the anterior 2/3. This sulcus terminalis divides it into the anterior 2/3 and the posterior 1/3. Anterior 2/3 is covered with the papillae, mainly the fungiform papillae, filiform papillae, types of papillae, fungiform, filiform, and the circumvallate papillae in front of the sulcus terminalis. At the tip, we have the filiform papillae. Now, this anterior 2/3 part is one that is visible and also can be able to palpate. But the posterior 1/3 cannot be palpated. It can only be palpated, it cannot be visualized. Okay. The muscles of the tongue are 2 types, the intrinsic muscles and the extrinsic muscles. Intrinsic muscles being superior longitudinal, inferior longitudinal, the transverse muscle, and the vertical muscles. Extrinsic muscles, those that are attaching the tongue to the external surface, that is the gingival glossus, hyoglossus, styloglossus, and palatoglossus. Mathematical representation is superior longitudinal and the inferior longitudinal. In between the transverse muscle and the vertical muscles. This is the intrinsic muscle. Now the extrinsic muscles are attaching the tongue to the external structures like the genioglossus, the genioglossus, geniohyoid, myohyoid, palatoglossus. Now the movements of the tongue, how does it feasible? Forward protrusion of the tongue is because mostly with the help of genioglossus. And this is what that is mostly affected in carcinoma. So the genioglossus is the muscle forming the bulk of the tongue, and this is what is affected in carcinoma, hence affecting the forward protrusion of the tongue in carcinoma of the tongue. The backward movement is because of its styloglossus. Next, the elevation higher up because of the palatoglossus. The depression is hyoglossus again down. Blood supply, we all know, it is supplied by the lingual artery, which is the branch of external carotid artery. Vein, same deep lingual vein drains it into the facial vein or into the internal jugular vein. The lymphatic drainage is most important. When you talk about the carcinoma of the tongue, lymphatic drainage is important. The tip of the tongue, it drains bilaterally into the submental nodes. The right half of the anterior 2/3 and the left half of the anterior 2/3 will drain into the respective submandibular nodes. This centrally located region may drain directly into submental or submandibular or also into the upper deep jugular digastric lymph nodes. And the posterior third, it drains directly into the deep cervical nodes on both sides. Jugular digastric, deep cervical lymph nodes on both sides. Now all this to form a network of jugulo-omohyoid lymphatic plexus. Okay. Next, to have an idea about the development of the tongue, the anterior two-thirds is developed from the first brachial arch to two lingual swellings, lingual processes, and one tuberculum in part. So this part forms the anterior two-thirds of the tongue. This is supplied by the lingual nerve for general sensation and by the chorda tympani for taste sensation, specific sensation, taste by chorda tympani. The posterior one-third is developed from the third brachial arch, from the cranial half of the hypobrachial eminence. Okay, hypobrachial eminence. So this is supplied by the glossopharyngeal nerve, the ninth cranial nerve, for both general and taste sensations. Okay, and the junction of these two is the foramen cecum. The posterior most part is developed from the fourth arch. It is supplied by the vagus nerve. Muscles of the tongue are derived from the occipital myotones, which is supplied by the hypoglossal nerve, except for the palatoglossus. Hence, all the muscles of the tongue are supplied by the hypoglossal, except the palatoglossus, which is supplied by the cranial part of the accessory nerve. Again, the same motor supply of the tongue. All muscles, as I told you, are supplied by the hypoglossal nerve, except the palatoglossus. This palatoglossus is supplied by the accessory nerve. Sensory supply, lingual nerve, general sensation, chorda tympani takes sensation in the anterior two-thirds, and posterior one-thirds is by the glossopharyngeal nerve. The posterior most part is supplied by the vagus nerve. Now coming to the benign conditions on the tongue. Firstly, we talk about the tongue ulcers. First one is a dental ulcer, which is the most common ulcers to see on the sides of the tongue because of a sharp tooth, irritating or denture, and a broken tooth. So these ulcers are mostly painful and they are self-limiting. They have a healing edge, so they will heal by themselves once the causative factor is removed. So these are self-limiting but painful ulcers. However, when there is repeated trauma on the causative factors such as sharp tooth or denture or a broken tooth, when not removed, there is chronic irritation forming an indolent chronic ulcer. This may mimic a carcinoma. It should be excised. As I already told you, carcinomas, pre-malignant conditions are repeated trauma. So such chronic indolent dental ulcers have to be excised and removed. Next is the most common actus ulcers that we already talked when we were talking about the buccal mucosa. There are exactly types on the tongue, minor and major. Minor ones are seen in menstruating women with painful brown yellow based ulcer and a red margin. They regress on their own. Major ones, which are larger than the minor ones, are large and are very deep. So they may become chronic and take more time to subside, to resolve. Sometimes they resolve with a scar. Chlorhexidine gluconate and local application of triamcinolone acetate, choline salicylate gel may be helpful in healing of these ulcers. Next, coming to syphilitic ulcers. It's the extragenital manifestations of syphilis. In primary syphilis, we get to see a painless, shorty ulcer on the tongue, mostly on the dorsum, with involvement of the submental and submandibular lymph nodes invariably. Next, in secondary syphilis, here there are multiple, very shallow, they're not deep, they're shallow, snail track-like ulcers in the margins. Here, and there's also present on we also present on the undersurface. This is important. They also have mucus patches on the tongues and also on the fauces. Here, condyloma, Hutchinson's condyloma, which is pathognomic of secondary syphilis, may be seen in the midline of the tongue, anterior of the tongue. Next, in tertiary syphilis, you have the typical gummatous ulcers on the anterior two-thirds, which have the typical punched out edges. They are painless and they have washed leather slough. They're covered with a washed leather slough. What is the main pathology here is endarteritis. This is more prone to Development. Additionally, syphilis, more prone, syphilitic ulcer is more prone to development of carcinoma in situ. Now, this carcinoma, this type of carcinomatic ulcers, here radiotherapy is not advised because I told you this is an endarteritis. There will be no RTNs once you excise it and then it's subjected to radiotherapy. Hence, there will be further compromise of its blood supply of the area, and hence it may lead to necrosis of that particular area. So, syphilitic ulcers, the causative factors of a carcinoma, there you have to be cautious when you are advising radiotherapy. This is just a simple point that you have to remember. Next, coming to tuberculous ulcers, again there will be multiple painful ulcers here with undermined edges. They are not very deep. They can occur mostly on the tip, on the margin, may also occur on the tip. Here, again, important thing is involvement of the neck lymph nodes, which have secondary tubercular changes. Associated tuberculous larynx and lung may also be present. May be present, may not be present. Next, herpetic lingual ulcer is nothing but just the involvement of the lingual nerve ulcers along the lingual nerve, presenting as acute neuralgia, severe pain with vesicles which form multiple superficial painful ulcers. These are all superficial but very painful ulcers because of involvement of the lingual nerve. Other ulcers, one is smokers ulcers, same smokers, they are usually often multiple, and presence of glossitis is significant. Post-pertussis ulcer and whooping cough occurs on the upper part of the frenulum linguae and the tip on the surface of the tip of the tongue. Okay, these are just to remember the various types of ulcers on the tongue. Next, coming to macroglossia, also called megaloglossia or pachyglossia. This is nothing but a disorder in which the tongue is larger than the normal size. It is caused by an increase in the amount of the volume of the tissue of the tongue, rather than a growth of external tumor. So it is usually painless with diffuse enlargement of the tongue. There is diffuse enlargement of the tongue. The most common causes are syndromes like Down syndrome, Becker-Friedman syndrome. Also, hemangioma and lymphangioma of the tongue will cause macroglossia. The other causes are acromegaly, mucopolysaccaridosis, and primary amyloidosis, deposition of amyloids in the tongue. So when the cause is lymphangioma, the tongue is soft, painless, with ulcers on both sides. Here, that because of difficulty in closure of the lip and jaw, you find ulcers. Hemangioma, again the same, soft and they're fluctuant. They're compressible because of blood vessels, and they're bluish or red in color. They may bleed or trauma. So treatment for macroglossia in general, when they're lymphangioma, the cause is lymphangioma, hemangioma, we may try to inject a sclerosant like ethanolamine allicholate. If this is failed, then we have to go for partial excision of the excess part of the tongue. Also, in neurofibroma, tongue muscular hypertrophy, we go for partial excision. This elongation of the tongue in a macroglossia is corrected by wedge section of the anterior part, the extra part of the tongue that is protruding. That part is resected in a wedge shape. The vertical thickening is rectified by slice cutting of the lateral margins. The lateral margins are cut. But here you have to be very cautious while you are excising the lateral margin not to injure the lingual artery and the lingual nerve. Next, coming to glossitis, inflammation of the tongue. The various types of glossitis, just have an idea. The median rhomboid glossitis, the central part median. It is smooth, lobulated, triangular patch on the anterior surface of the anterior tooths of the trunk in front of the foramen cecum in the midline. Okay. Here on top of this glossitis, there may be secondary back candida infection. This may mimic carcinoma, so we have to take a biopsy to rule out malignancy. The second one is geographic tongue, also called glossitis migrans. It begins as a benign small red patches with a white furred margin. Red patches with a white furred margin. Here there is remission and regression. It spreads and recedes also, haphazardly. So we have fresh patches and old healing patches also. Now this white margin that we've seen here, it contains the keratinized epithelium and inflammatory cells. Okay? So this type of glossitis is seen mostly in patients with congenital heart disease and also acute GI diseases. Hunter's glossitis, it's seen in pernicious anemia. Hairy tongue is an overgrowth, if nothing but just overgrowth of filiform papillae with deposition of black or brownish stains on it, and secondarily bacteria or fungal and tobacco staining. This is not actually the presence of hairs per se. It is a misnomer. So it is not hairs that gives the blackish discoloration. It is by the bacterial or fungal or tobacco staining on the overgrown filiform papillae. So just cessation of the causative agent and the scraping of this superficial scraping of this excess papillae provided with the proper orodental hygiene is enough to treat hairy tongue. Okay. Next, the types of glossitis are like granulocytosis glossitis, lagna glossitis, deficiency of vitamin B3, niacin or nicotinamide that causes pellagra, dementia, dermatitis and diarrhea, and glossitis are the classical features of this type of deficiency disorder. The other important topic that you can be asked for 2 marks is a tongue tie. It is nothing but it's a frenulum lunae that attaches the anterior tooths of the tongue to the floor of the mouth. Here, this frenulum lunae becomes short and it is thick and fibrotic. Hence, the tongue there is difficulty in protrusion of the tongue. So, during protrusion, what happens? The lateral margins and tip of the tongue is everted. The dorsal midpart heaping in the middle. The dorsal midpart is heaping and this is everted. The lateral margins are everted. So what are the difficulties in tongue tie? Obviously you need tongue articulation for proper speech production. So there will be difficulty in speech and difficulty in cleaning the inner part of the lower teeth. So inner part of the lower teeth when they are not properly exposed because of this tongue tie, that is the frenulum pulling tongue below, there is difficulty in cleaning the lower part. So how do you treat this? Just nothing, simple excision under local anesthesia in adults. In children, we have to use general anesthesia. The tongue is lifted upwards. Stay suture at the tip is applied to hold the tongue in place. This fibrous frenulum is divided using fine scissors. The linear wound that is closed, that is created, linear wound has to be closed longitudinally using catheters. Obviously, abdominal sutures catheter. Okay. From the tip towards the floor. Next, coming to the topic of our today is carcinoma of tongue. There is carcinoma of tongue. It is equal in both the sexes, but there is increased incidence of carcinoma in the females because of increasing number of female smokers. Here, this picture is showing you. I told you about field cancerization, wherein there are multiple secondary primary tumors. See, all these are second primary tumors on the tongue. This appears to be a synchronous type of field cancerization. Now, what are the etiology? Anywhere in the oral cavity, you have to mention the same etiology. All malignancies in the oral cavity, the same etiology. Leukoplakia, erythroplakia more predominant. All SS are the causative factors and the predisposing factors, spices. Malignant conditions, HPV, human papillomavirus, Epstein-Barr virus are the causative agents. Again, same malignant conditions and lesions, leukoplakia, erythroplakia, chronic hypoplastic candidiasis, oral submucous fibrosis, pseudoperoneal dysphagia, and symptomatic glossitis, mostly tertiary symptomatic glossitis. Into the types of carcinoma in the tongue, it may be papillary growth or ulcerative or ulcerative proliferative. This kind of carcinoma tongue is more common, almost 60% ulcerative or ulcerative proliferative growths. There may be fissures with surrounding indulation or lobulated indulated mass. Here, the entire tongue is frozen because of indulation. This is the papillary type, ulcerative proliferative type, fissure type, and this is the frozen tongue. Histologically, the most common presentation is squamous cell carcinoma most of the times, but it may be adenocarcinoma when it is arising from the minor salivary glands on the tongue or the mucous glands. The other possibilities could be melanomas and lymphotic gliomas. Sites, most commonly carcinoma tongue occurs on the lateral margins. It may also be next in common is the posterior one-third. Ventral surface, it is 9%. On the tip, it may also occur on the tip, 10%. Coming to the clinical features, the patient presents with a painless ulcer initially or a swelling, if it is a proliferative type, papillary type, this is swelling on the tongue. Later, it may become painful when there is infection, secondary infection or the ulceration over the swelling. Or on the lateral margins when there is involvement of the lingual nerve, then there is pain. This pain is referred otalgia referred to the ear because of quadratum tongue. Pain on the swell. There is also difficulty in swallowing or painful swallowing. When the posterior one-third of the tongue is involved, posterior one-third is involved, then we have dysphagia. There is excessive salivation, and this saliva often is blood-stained because of the ulcer. Dysphagia can be because of three causes. Because of the involvement of the entire tongue, when there is no movement of the tongue, the tongue is fixed, or the involvement of the genioglossus muscle, and also as told when the growth is on the posterior one-third of the tongue, then we'll have dysphagia. The three causes of dysphagia and carcinoma tongue as follows. Next, anterior two-thirds of the tongue, the visible ulcer that is seen, it has the following features. One, it bleeds on touch. Also, the edge is usually everted. Mostly it is everted. The base and surrounding areas are indurated. Classical features of carcinomatous ulcers. This indurated area is often extensive, sometimes more than the involved primary tumor area. It is everted, and the ulcer sometimes may cross the midline, and it may extend onto the opposite side, and then onto the floor of the mouth more commonly, or sometimes onto the annulus and the mandible. So these are the involvement of the adjacent structures and in advanced stages. On the usually on the posterior one-third, I said we cannot see these ulcers, they can be palpated only. Inability to articulate is another finding. Fetal halitosis, it is because of infection necrosis of the oral ulcer in the oral cavity. In posterior one-third tumors, there is most important change in voice. Movements of the tongue, especially forward protrusion, is commonly affected. It's called ankylosis because of the involvement of genioglossus. Again, the patient will also present with palpable lymph nodes in the submental and submandible, also in the upper trigonodigastric. TNM staging, already told to you. TX, where the primary tumor cannot be assessed. TIS is carcinoma in situ. T1 less than 2 centimeters. T2 is 2 to 4 centimeters. T3 is 3 to 4 to 6 centimeters. T4 usually of any size but involving with the adjacent structures. T4 is an advanced stage wherein the mandible, the skin, the buccal and mucosa may also be involved. Next, N of the TNM classification, N involves the regional lymph nodes. Metastasis on the same side less than 3 centimeters is N1. N2 is same side but 3 to 6 centimeters. 2A single, 2B is multiple. 2C, bilateral on both sides or on the opposite side. But the size of the lymph node is not more than 6 centimeters in N2 classification. N3, again the size is 6 centimeters, it may be present on the same side or on the opposite side. N1, evidence of distant metastasis present. So this is TNM staging. The same for all oral cavity malignancies. Next, TNM, based on this TNM classification of AGCC, staging of is as follows. Stage 1, only T1 is there. Stage 2 is T2. Stage 3, you have T1, 2 or 3, but N1 present. So stage 3 is involvement of the regional lymph nodes on the same side. Okay, so stage 3. Now stage 4 is either the tumor size is more than 6 and it is involving the adjacent structures, that is T4, or T1 or 2 or 3 with N2 disease, that is 4 to 6 centimeters nodal size on the same side or the opposite side. 4B will be N3. Okay. Now 4C is distant metastasis present, is advanced carcinoma. So what are the investigations? The same. Over the site, over the ulcer, we'll have to go for an edge-wedge biopsy involving part of the normal tissue also on the edge. And on biopsy and histopathological examination, we get to see squamous cell carcinomas with the typical keratin pearls. Next, when there is involved neck lymph nodes, we have to confirm that they are secondary nodes by NFNAC, final aspiration cytology. Now, these posterior lesions on the posterior 1/3, they cannot be seen, so they'll have to be visualized with the help of an indirect learning microscope available in the OPD. And further, for the extent of the lesions and the spread of the lesions, you have to go for a CT when it is involving the bone, or an MRI, simple MRI will give you soft tissue delineation. Chest X-ray to be taken, rule out the extent spread to the distant metastasis to the lung. Management, mainly it is surgery and radiotherapy. And smaller lesions, it is the same for any nodal malignancy. Smaller lesions, if it is feasible for radiotherapy or brachytherapy, we will go for brachytherapy. No, it is feasible for surgery also. Simple wide local excision would be sufficient. It is done for smaller lesions. With the larger lesions, you have to go for first initial excision and then followed by radiation, combination of both. Next, when the neck lymph nodes are involved, then you have to go for modified radical neck dissection. The various types of modified radical neck dissection depending upon the involvement of the nodes. Okay. T1 and 2, I told you the same smaller lesions, either surgery or radiotherapy in combination or alone. T3 and T4, combination of chemoradiotherapy and surgery. Advanced stage of diseases wherein there is extensive neck nodal lymph nodal involvement and distant metastasis, or obviously it is palliative therapy. Palliation at the local site to evade complications, you may go for wide excision and followed by chemoradiation. So surgery, less than 1 centimeter size tumor on the tongue, and also carcinoma in situ. This initial carcinoma, just wide local excision with involvement with clearance of 1 centimeters, both in the size around the ulcer, around the lesion, and in depth. Okay. Another advancement is usage of laser diode, carbon dioxide laser or diode can be used for excision. And this, remember, this is done in smaller size tumors as small as less than 1 centimeters. If it is 1 to 2 centimeters, we will have to go for partial resecting, that is in excision of the tumor along with the inward tongue, inward part of the tongue. Here, you need to have 2 centimeter clearance from the margin of the lesion, both in size and depth. This is done on the anterior 2/3. So, 1 centimeter tumor, less than 1 centimeter, simple wide excision of this tumor and primary closure, after ensuring at least 1 centimeter clearance. This is important. 1 centimeter clearance is enough in a smaller tumor. To 1 to 2 centimeters, then we'll have to go for partial vasectomy in excision of this part of the tongue ensuring 2 centimeter clearance both from the margin and depth of the tumor. Now, tumors larger than 2 centimeters, hemiglossectomy, that is, that half of the tongue is removed on one side up to the sulcus terminalis. So, this half of the tongue, the anterior 2/3, is removed up to the sulcus terminalis. So, when the tumor is greater than 2 centimeters, this has to be done. Now, the raw area that is produced because of the excision of the lesion, in smaller areas, it can be left alone for primary closure, for healing by granulation and epithelialization. Or in smaller lesions, it can be caused by primary suturing itself. Wide areas of raw areas after excision, they have to be covered with flaps. So reconstruction has to be done. The most common flap here used here is pectoralis major muscular flap or the quilted split skin flap. Okay. Most commonly used is this pectoralis major muscular flap. Tip of the tongue, then this wide excision is done. Large primary tumors, there is an option of giving preoperative radiotherapy in order to downstage the disease, followed by surgical excision or hemiglossectomy. Same side palpable mobile lymph nodes, then you have to do a radical neck dissection, blood dissection. Modified radical neck dissection. Radical neck dissection on the same side. If opposite side lymph nodes are also involved, then you have to do radical neck dissection on the involved side and functional neck dissection on the opposite side. Okay. Again, bilateral mobile lymph nodes, one side radical blood dissection, other side functional dissection, wherein you have to preserve the internal jugular vein so as to maintain the cerebral flow, blood flow. Next, this so far discussed was about the anterior 2/3 involvement of the tongue in carcinomas. When the posterior third is involved, then here also we go for excision or glossectomy by a lip split incision and mandible dissection. So invariably, the posterior third lesions will involve the mandible also. So mandible dissection has to be done. The total glossectomy is done. It is not done as it carries significant morbidity and mortality. So this kind of total excision and hemimandibulectomy is usually not done because of its morbidity. And also the loss of various functions, speech, swallowing, aspiration, complication, and sepsis is there. So this kind of approach is usually not done. Only a palliation is done when, as and when indicated. So this is important. What is commando operation? I've already told this about in the previous classes. It's nothing but the wide local excision, wide excision of the tumor. In case of a tongue, it is hemiglossectomy, whereas half of the tongue is removed, along with hemimandibulectomy and radical neck dissection. Radical neck dissection on the involved side. So this is called the commando operation. This is a picture that is showing you the commando operation. The lip split incision is given, where here mandibulotomy will also be done in continuation with the neck dissection. Okay. The primary tumor resection is done here. The primary tumor has to be excised still. It's part of the tumor. Mandible has been excised. Hemimandibulectomy has already been done. The final hemimandibulectomy along with the neck nodal clearance. Okay, we have cleared the level 1, 2, and 3 groups of lymph nodes, exposing the alveoli. This is a commando operation. Now, what are the advantages? Obviously, surgery, it has some of its own advantages. You can have a specimen for histopathological examination, so confirmation, and to know the extent of the disease also it is useful. Surgical excision. Short-term compliance is present. It also helps in planning of the adjuvant treatment. There is no sequelae with as in radiation and chemotherapy. So that is advantage. But the disadvantage is obviously you are compromising on the function because of excision of the involved areas. There's disfigurement. There can also be additional bleeding, infection, secondary infection, and mortality. Coming to radiotherapy. I told you small primary tumors less than 1 centimeters. There is curative brachytherapy, radiotherapy, and brachytherapy using cesium needles, cesium or radium-192 needles. Primary tumors, large primary tumors. For secondary, uh, uh, tumor size reduction or down staging of the tumor, you can get preoperative radiotherapy. In advanced stages for palliation. Also, when lymph nodes, advanced like lymph nodes, mid-fixed, that are fixed and involving the skin, you can go for palliation radiotherapy. Also, post-operative radiotherapy will prevent relapses. On the posterior one-third, I told you surgery is not feasible, not advisable because of its morbid condition. Hence, you can go for either curative or palliation radiotherapy. These are the indications. Complications of radiotherapy, anywhere it's the same. Here on the tongue, there is loss of sensation like taste on the tongue. Then, can also be ankyloglossia and trismus. Infection, secondary infection, post-radiotherapy is very important. They can be pharyngeal and laryngeal edema. Hence, you have to take care of the airway post-radiotherapy. Dermatitis and skin infection is common for any radiotherapy anywhere in the body. Coming to chemotherapy. It is curative. It is done in neoadjuvant cases like this, like in before the surgery, or adjuvant along with surgery or radiation adjuvant. It is done. It's given along with radiotherapy to treat the distant micrometastasis. In case of palliation, to prevent metastatic, to cure the metastatic, it is just to prevent the damaging effects of distant metastasis and also prevent recurrence in palliation. Just have to mention about the Price-Hill region that is used for chemotherapy, nodal cavity. The most common drugs that are used are methotrexate, vincristine, adriamycin, and bleomycin. So, prognostic factors, carcinoma tongue usually carries a poor prognosis, and the indicators of poor prognosis are when the tumor thickness, not the size of the tumor thickness, that is depth of the tumor is more than 4 millimeters. That is deeper tumors, deeper onset tumors, and also histologically when they are poorly differentiated, high-grade tumors. Poorly differentiated, that means the keratin pearls are very less. That is poorly differentiation. Or high-grade tumors, that is extensive vascular and neural invasion. Then there is perineural invasion and lymphatic invasion. Yes, it is poor prognostic factor. Also, DNA ploidy, polyploidy, and aneuploidy can have worse prognosis. Okay. Depending upon the staging of the disease, stage 1 has comparatively better prognosis, better 5-year survival rate up to 90%. But stage 4 has a poor prognosis, as low as less than 20%. So, in a nutshell, the tumors of the oropharynx. These involve the tumors of the oral cavity and the oropharyngeal region, the upper part of the pharynx. So these are not usually eligible for surgery because of the morbid exposure to resection. On the tongue-based tumors, they may require total biosectomy. But I told you this has a morbid condition, so we usually do not go for resection. We just go for palliative or curative radiotherapy. Next, tumors of the soft palate and tonsil, either primary surgery in continuation with the neck dissection can be done, and this primary defects of the excision can be closed with a forearm flap in case of a tonsillar tumor, the soft palate tumor, combined reconstruction consisting of superiorly the pharyngeal flap so as to show towards the nasal surface. Towards the oral surface, you can use the forearm flap. So the combined reconstruction procedure in case of soft palate excision in carcinomas. This again is followed by primary radiotherapy also. Now, in patients with large volume neck disease, that is the extensive involvement of the lymph nodes on both sides more than 6 centimeters, then there is combined modality of neck dissection followed by chemoradiotherapy. Okay, so chemoradiotherapy in conjunction with the primary surgical excision is being followed popularly in order to preserve the functions of swallowing and speech. Okay. A combination chemotherapy may also be given, wherein there is combined usage of platinum agents and hydrofluorouracil. Management of the neck in the case of oropharyngeal carcinomas. Here there is increased popularity of usage of conduction of supraomahyoid neck dissection because of presence of occult metastasis even in clinically negative neck lymph nodes. That is, clinically there are no lymph nodes palpable, but we do go for supraomahyoid neck dissection in such cases because of the possibility of presence of neck occult metastasis as much as 30%. So levels 1, 2, and 3 are removed in supraomahyoid neck dissection along with primary tumor excision. Clinically positive neck, where neck lymph nodes are positive. If it is less than on the same side and less than 3 centimeters, we'll go for selective supraomahyoid neck dissection. This is the incision that is given to go for neck dissection. The area of the neck lymph nodes that are removed, levels 1, 2, and 3. Levels 1, 2, and 3 are removed, bearing the IJV. Okay. Preserve the spinal accessory, IJV, and the sternocleidomastoid. In 2A and 2B disease, radical or modified radical neck dissection, followed by postoperative radiotherapy is important. In N2C disease, that is advanced stage, bilateral, then this present on both sides. Usually the primary tumor is most commonly inoperable. It is advanced and inoperable. So, in such cases, if it is operable, then we go for bilateral neck dissection. I told you, same side, radical neck dissection, opposite side, functional neck dissection. Opposite side, presumably there is lesser involvement of lymph nodes. Then we'll go for functional neck dissection, along with postoperative radiotherapy. N3 disease, extensive involvement of the neck with advanced primary tumor, primary disease. So radical neck dissection may or may not be performed, but radiotherapy will be given postoperatively for palliation. Also, radiotherapy, if the primary tumor itself is involving the internal carotid artery and the skull base, then you have to go for radiotherapy of the neck also. So these are various types of neck dissection. The lymph nodes that are removed, supraomahyoid dissection, we go for levels 1 to 3 lymph node removal, usually in clinically neck negative and N1 disease. Next, extended supraomahyoid neck dissection, wherein the up to 4th level of lymph nodes are removed. It's usually done in tongue cancers, and also neck in oral cancers, tongue cancers with like N0 or N1. Now N2 and N3, there is radical neck dissection compulsorily. N2 and N3 we go for radical full radical lymph nodal dissection, wherein levels 1 to 5 lymph nodes are removed. Modified radical neck dissection can be done as a palliation when there is involvement of the neck skin, and also after recurrence from selective neck dissection, wherein 1 to 5 levels of lymph nodes are removed, but since it is modified, you will have to preserve the internal jugular vein, the spinal accessory. You may or may not preserve the sternocleidomastoid on that side. Okay? So this is modified radical neck dissection. What are the complications of treatment of the oropharyngeal cancer? Surgical, obviously. When you injure the accessory nerve, there is palsy, there is shoulder dysfunction, and severe pain. Also, soft tissue will be edema in case of bilateral neck dissection. There may also be injury to the phrenic nerve, thoracic duct on the left side, cranial nerve injuries, the rupture of the carotid artery causing potential hemorrhage. Complications of radiotherapy, first radionecrosis of the mandible, there's hypothyroidism because radiotherapy involving the affecting the thyroid gland. Then there is fibrosis of the carotid artery, also trismus, xerostomia, visual impairment, radiation neuritis. These are the complications of radiotherapy in oropharyngeal carcinomas. In specific, for radiotherapy enabled, you can write common complications. Next, chemotherapy, again commonly, nausea and vomiting, diarrhea, stomatitis, GI upset, leukopenia is important, and thrombocytopenia. Okay, so this to end the oropharyngeal carcinomas. The outcome and prognosis, again as stage advances, stage 4, it is poor survival, 5-year survival rate as well as much as 30%. Okay. So I finished with the oral cavity and its oral cavity malignancies. So if you have any doubts so far, you can ask me. Or I hope you're going home and you're going back after the class and revising the topics. You can now ask me doubts on the topics covered so far. I hope I have been clear to you. On the topics of oral cavity malignancies, you'll be given 4-mark questions on the pre-malignant conditions like leukoplakia, erythroplakia, also carcinoma tongue or buccal cavity, buccal mucosal carcinomas can be asked to you in your examination. Otherwise, practical purposes, you just have to remember the basics of oropharyngeal carcinomas and their management. That would be sufficient to cover the topic. I have covered the entire topic, but also a revision on the oropharyngeal carcinomas. So I assume there are no doubts from your side, either because you have not understood or maybe because you've understood so well. Okay, so if you mind, you can ask me your doubts whenever you want to. So, the next I'll be covering on the topics of facial maxillary diseases also. So for this class, I'll just cover few important topics in facial maxillary diseases. And then I'll start with cleft lip and cleft palate in my next class. That would take me an entire class. So I just thought I will finish off these smaller topics, which are important in your examination point of view. You will be asked 2 or 4 marks questions on these topics that I'm going to talk to you in the next 10 minutes. Okay. So one is lupus. Lupus is nothing but swelling arising from the mucoperiosteum of the gums. Lupus arising from the gums. So lupus. Various types of lupus. One is conjunctivitis. It is a benign condition seen in newborn. Conjunctivitis. So it is arising from the gum pads. It's called Newman's tumor, arising from the gum pads in a newborn. Okay, so it's nothing but a variant of granular cell myoblastoma, which originates from the gums. Okay? It's more common in girls and more common in the upper jaw, usually in the base of the canines, on the premolar area. So, on the lateral aspects, on the canines or on the premolar areas. It is not a malignant condition. Here, clinically, there is well-localized swelling arising from the gums, which is firm and it bleeds on touch. Okay, so simple excision of this lesion will subside the symptoms. Next type of lupus is fibrous lupus. It is the commonest type of lupus in the adults. It is a benign condition and can occur anywhere on the on the gums, both males and females. It is a red, firm, hard, can be sessile or pedunculated. Mostly they are sessile. It is, by name itself suggests it is fibroma, arising from the periodontal membranes. Periodontal membrane fibrous thickness arises. Here, clinical features are they are painless, well localized, non-tender, hard, they are hard, important. Fibrous, it is fibrous, it is a fibrous tissue origin, so it is hard, and they are non-tender on the gums, but which again will bleed on touch. So bleeding on touch will be a second differential diagnosis you should be having in mind is a squamous cell carcinoma on the gingiva. So it's also hard. So squamous cell carcinoma is a differential diagnosis. Treatment is excision with the extraction of the adjacent tooth. So the adjacent tooth also has to be excised so as to remove the entire periodontal membrane that may be involved. Recurrence can occur if it is not properly removed. That's what I told. When the periodontal membrane, the adjacent tooth, that when the membrane is not peeled off properly along with the tooth, there are chances of recurrence when it is left behind. Next, there is another common condition of pregnancy lupus seen in pregnant women. It's nothing but an inflammatory gingivitis. It is just because of inflammation during the third month of pregnancy, usually in the third month of pregnancy. It resembles a fibrous lupus on examination. Also, secondarily, there can be phylogenetic granuloma formation. It will resolve usually spontaneously after delivery. If it is not resolving, then we have to go to simple excision. So this is example of the fibrous lupus. So when you have to remove this localized tumor along with the tooth extraction. The other types of lupus, just know the names. Lupus fissuratum, because of benign hyperplasia of the fibrous tissue that develops as a reaction of chronic irritation on the gingiva because of ill-fitting dentures. Next is myelomatous lupus. It is seen in leukemic patients. So once the treatment of leukemia has been given, then this also will resolve. Next is granulomatous lupus. It is nothing but a granulation tissue on the gum around the caries infected tooth. So that is granulomatous lupus. This over the gums, there is formation of a granulation tissue around the caries tooth. Caries tooth is where the infection is there. So here there are every chances of secondary infection of this lupus also, and also it bleeds on touch because of secondary infection. Next is giant cell lupus. So in osteoblastoma, it causes ulceration and hemorrhage of the gum. This is giant cell lupus. Next, carcinoma lupus, seen here, squamous cell carcinoma of the alveolus or the gum. It presents as a localized hard indurated swelling with superciliary ulceration. Next is fibrosarcomatous lupus. Here, fibrosarcoma arising from the fibrous tissue of the gum. So these are the various types of lupus. Just have to mention about these names if you can remember. But important thing, we have to mention about the congenital lupus and the fibrous lupus. Okay. So this will cover about the lupus for 4 months or 2 months. The other important topic is dentigerous cyst, also called as follicular odontome. It is nothing but a uniocular cystic swelling that arises in relation to the dental epithelium from an unerupted tooth. So, the unerupted tooth epithelium, it will give rise to a cystic swelling, uniocular, simple uniocular cystic swelling in relation to an unerupted tooth. Okay? So, unerupted tooth, more commonly they are seen on the lower jaws. It is more common, the last molars. But it is not that it is not occurring in upper jaw. It may be present in the upper jaw also, but more commonly the dentigerous is occurring in the lower jaws or the crown of the unerupted tooth. So unerupted tooth is the important finding in case of a dentigerous cyst. This is commonly seen in relation to premolars and mostly in the molars. It causes expansion since it's unerupted tooth underneath, so there is expansion in the outer table of the mandible. So mandible, outer table expands, hence there is a swelling. over the jaw. So there is a smooth but hard swelling over the jaw clinically. Uh, and differential diagnosis is other jaw swellings. Jaw swellings like adenoma, another one is dental cyst, or the involvement of mandible osteoclastoma. This is a differential diagnosis. Patient will present with a painless swelling in the jaw, most common in the lower jaw. If there is presence of pain, secondary infection can be suspected. So, on taking an orthopontogram, OPG, nothing but an X-ray of the open mouth, you can see an unerected tooth at the base within the cyst. This is well-defined cyst, the presence of an unerected tooth underneath. Okay, this is a well-defined, this OPG is showing a well-defined cyst, a uniloculated cyst with an unerected tooth within it. Okay, so this is the important finding in OPG, orthopontogram, in case of a dentagerous cyst. The complication of the dentagerous cyst is it may turn into a tumor, jaw tumor, dental tumor. Treatment is simple. If the cyst is small, swelling is small, if simple excision is done. If it is large, there is initial marsupialization, like only marsupialization, wherein the edges of the cyst is sutured to the free edges of the surrounding tissue, so as to externalize the cystic swelling. Later, once the cyst is completely openly drained, then there is excision of the cyst. Along with excision, you should also remove the unerected tooth. So, unerected tooth should be extracted. This is must in case of a dentagerous cyst. Otherwise, there will be chances of recurrence. Okay. The topic is another topic, dental cyst, to be differentiated from a dentagerous cyst. Dental cyst, also called a radicular cyst or periapical cyst, is nothing but it occurs on the root of the chronically infected dead erupted tooth. Okay, so here the tooth is erupted, if it is infected, then there is on the root of this on the root of this erupted tooth there is infection. So this diamond is famous epithelium derived from the epithelial debris. Clinical features again, smooth, tender swelling. Here it is tender swelling. Because it is infected cyst, there usually presence of pain. So there is a tender swelling in the jaw in relation to the caries tooth. So tooth has to be prior infected, which causes expansion of the jawbone again. So the complication would be obviously involvement of the jawbone, osteomyelitis, infection of the jawbone, osteomyelitis of the jaw. Differential diagnosis again and dentagerous cyst. Clinical, the patient presents with a swelling in the jaw. So differential diagnosis would be a dentagerous cyst. Painful dentagerous cyst is a differential diagnosis. Investigation again, OPG. Here you get to see the absence of the unerected tooth on the OPG. So it's simple cyst without the presence of a tooth inside it. Okay, this is a differentiating finding in a dental cyst, from a dentagerous cyst. Here you can see this swelling in relation to the tooth, which seems to be infected also. The treatment is obviously there is infection, so you have to give drainage. You have to give antibiotics. If it is accumulated pus, then you have to go for the drainage of the cyst, and later on complete excision of the cyst along with the excision of the infected tooth. So this is important. Infected tooth along with the cyst has to be excised on a later date. Okay. So this have covered a few of the facial maxillary diseases that are asked for you as 2 or 4 more questions. So in the next class, I'll talk to you on cleft lip and cleft palate. So any doubts in the classes so far covered, you're always free to ask me. Thank you.